Hi everyone, my name is Farid Jalali. I am a gastroenterologist in California, and some of you may have seen some of the work and hypothesis that I've kind of shared online. Um, I want to thank Mark for having me here to kind of explain more of my thoughts. Who knows if I'm right or wrong, but let's just give it a go, and hopefully we'll stimulate some thoughts and finally figure out what's going on with COVID-19. This is kind of my early attempt in March to put it all together. Some of you may have seen this. Bottom line here is COVID-19 probably causes endothelial dysfunction. And at that point in time, I was really intrigued by how the D dimer kept rising and every other marker kept going down and patients kept getting worse. And I thought, well, there has to be a thrombosis somewhere. Who knows where it is, but maybe in the lungs, maybe somewhere else. But this is kind of the early attempt from March. And this is a later attempt to put it all kind of in, um, diagram that explains things a little bit easier, but the concept is the same. Microvascular thrombosis um, happening in the lung microvasculature, along with vasoconstriction from this virus. This is my attempt to kind of explain, and some of you may have seen this. I've posted these everywhere on the factors that on one hand could be risk factors for worsening disease state in COVID-19, and on one hand possibly protective factors. And I think some of this has you know has been thought of as possible and plausible, and some of it obviously is not confirmed at all, and it may not even be plausible. So again, my main message today is take everything with a little grain of salt. I'm obviously hypothesizing more than anything else, and I don't have complete proof of everything. But one thing I came across early on in March was this kind of graph and this data point from a Belgian PhD researcher who essentially showed that the little tiny blood vessels in COVID-19 are really, really constricted. Not just necessarily in the areas of the lung where the infection happens, but also seems like diffusely constricted. And this is data from him showing again the constriction and really the lack of evidence for presence of these really tiny blood vessels where you normally see them on CT. You don't really see them much in COVID-19. These are my later attempts to kind of explain what happens, physiologically in the lung microvasculature. Again, I won't spend too much time on this. I think it's been discussed over and over again, but bottom line here is alveolar capillaries are constricted, possibly some microthrombi, and you kind of get this, backflow built up in the precapillary arterioles. And we see CT evidence of this, that there is, vascular dilatations, you know, kind of associated with the areas that are inflamed in COVID-19 lung. For unclear reason, these vessels seem dilated and keep getting more and more and more dilated, and then they kind of disappear. Something happens to them where, either they break open and floodgates open and kind of the vessel loses its structure, or something else happens. It's really not clear, but this is kind of my attempt to show that, yes, this is probably happening. It seems plausible that it's happening. And there's probably some sort of an intrapulmonary vascular shunt that develops from, all the vessel formation and the vessel dilatation and the backflow that's created in COVID-19. And this shunt potentially would explain the low VQ mismatch, the hypoxia that we see in these patients before they get to their baby lung stage, very advanced stage, where we kind of just know what happens as it does in typical ARDS pictures that we see. Prone position, there's a thought process that possibly it does not necessarily work the same way as we think in regular ARDS kind of thought process, where prone position improves ventilation in dorsal lung. In these patients, there's a possibility, and it's been hotly debated, that prone position actually changes the vascular flow away probably from the areas that are affected to areas that are less affected by the endotheliitis and kind of the microthrombi that COVID causes. It is not proven that this is what's happening, but this is kind of my attempt to explain that, you know, kind of like hepatopulmonary syndrome, where is another disease where vascular shunting happens in the lungs and position changes do change hypoxia. This is possibly a plausible method where we see such a drastic response, especially with early COVID, to prone positioning, and the response is somewhat rapid. They almost improve their hypoxia, I don't know, within a couple minutes of proning. This slide is another attempt to kind of, you know, bring up the discussion on mechanical ventilation and COVID-19. I think by now we all kind of have heard that possibly early mechanical ventilation may not be the best thing to do. And potentially, you know, higher PEEP early on might not be exactly the best idea. I won't get into the details of this with any authority. I'm not a pulmonologist. I'll leave that for people that actually are experts at this. But I just want to bring up the idea, you know, of how we think this might happen. If you can imagine COVID-19 causing vasoconstriction and really just poor flow across the alveolar capillaries, these alveolar capillaries are essentially the flow within them are essentially, you know, highly regulated by how distended the alveoli themselves get with air. So if you essentially increase the distension of alveoli, you squeeze these little capillaries. And if they already are squeezed a little bit or more, and they already have some, you know, some crud in them, some microthrombi, and you basically suck the life out of these, you know, little lifeless capillaries that are there. So that's the entire concept, that, you know, increasing distension of the alveoli, at least in this disease, may not be the best, you know, best thing to do. It may increase the dead space ventilation, the high VQ mismatch, number one. And it may also increase the shunting, because the blood vessels that are not the alveolar capillaries, the ones that are kind of more inside, away from the alveoli, those actually have less resistance as the alveoli get more and more distended. And this concept has been shown over and over again in, you know, in pulmonary textbooks. And you may actually decrease the resistance in these shunts, and you may actually get more blood flow into the shunt, away from the alveoli where gas exchange is not really happening properly, and you can worsen the hypoxia as well. Same concept with increasing tidal volume. I don't think there's much debate there. Obviously, low tidal volume ventilation has always kind of been a cornerstone of mechanical ventilation. And kind of skipping through some of these slides, you know, I just want to kind of emphasize the newest article that came out in Lancet by Dr. Calfee and some other pulmonologists from Canada. Again, emphasizing the same core concepts. Low tidal volume ventilation, 6 milliliter per kilogram. And, you know, avoiding higher PEEP, especially in early disease, possibly is the right thing to do. They once again echo the same sentiment that you could worsen the pulmonary vascular pathology and cause barotrauma and other things by higher PEEP. And the gain that you get from oxygenation in higher PEEP may be misleading. It may not be the best outcome for the patient to have their arterial oxygenation go from 55 to 70 by going up from a PEEP of 8 to, I don't know, 12. And, you know, instead, the physiology of the disease is getting worse. These alveolar capillaries, the lifeless little capillaries, are probably getting more and more squeezed, and more dead space happens, and more, you know, and the disease just progresses more rapidly in that sense. Um, Talks about prone positioning and talks about really not intubating early unless you have objective evidence that you need to intubate, such as objective evidence of worker breathing getting worse or really refractory hypoxemia and hypercapnia. So getting to the topic that's really most important to me, and maybe helpful in figuring out where else to go after this, after now, with COVID-19 is really what is the true model of injury? Is it just microthrombi? Is it just a hypercoagulable state? What cells are kind of involved here? And I'll present some evidence, some hypothesis. I'll acknowledge that we don't have any clear answers, but I think we're more and more focusing on possibly the platelets playing a major role here. So for COVID-19, these are the steps, essentially, how the infection happens. We think the alveolar injury happens as the cells you breathe in, the virus causes injury to the alveoli, and they kind of cross over from the alveoli to the endothelial side, cause some endothelial dysfunction. And really a protective response happens here, where I guess 90% of people do this very well, and I hope I'm in that 90%, but you basically get a bunch of platelets and leukocytes and whatnot come to the area of endothelial laceration. It's essentially an injury there by the virus, and say, okay, let me patch this area up. I'm gonna close this off and make sure the virus doesn't get out, and make sure I heal up the area. And it probably happens very well in a very regulated fashion in vast majority of patients. But in those that proceed to severe disease, we have evidence from New England Journal of Medicine autopsy. They have 9 times as prevalent degree of microthrombi in their alveolar capillaries, and they have almost 3 times the level of vascular neogenesis in these pulmonary microvasculature compared to influenza ARDS, which in and of itself is another type of ARDS, another cause for ARDS that has been associated with high kind of thrombotic events, MIs and other things. And COVID seems to be at least have evidence on autopsy, on histology, to have 9 times the potential of causing more capillary microthrombi. Microthrombi on the left, vascular neogenesis on the right from the same article. This essentially goes over what cells could be injured in COVID-19 injury. Is it the endothelial cells themselves? Is it something around there? And there seems to be some evidence showing that parasites, which kind of act like a little binder that holds the endothelial cells together. They don't have smooth muscle cells to hold them together like arteries and whatnot, but they have this layer just outside of endothelium where these parasites kind of hold the endothelial integrity. And there seems to be lots of ACE2 receptors there. And this shows histologically that these parasites are lost in COVID-19 infected patients. And finally, NYU autopsy showing that there's lots of platelets and lots of kind of megakaryocytes abnormally in not just the lungs, but also other organs, heart, kidneys, elsewhere in these severe COVID-19 patients, despite having full anticoagulation, I might add. So it really raises the question, are we treating the right subject with anticoagulation? Is there a point where increased anticoagulation with heparin is not dealing with the platelets? Kind of like MI. I mean, we're not, I don't think we're treating, MIs with heparin drip all the way through and Eliquis after that to go home. I mean, they need antiplatelets for a reason. And who knows? I think there's something similar to what's happening in COVID. 50% of body's platelets are produced in the pulmonary circulation. I had no idea this was the case. And I think this is a study recently out of UCSF by Dr. Looney, that showed unequivocally clear evidence that at least about 50% of platelet biogenesis happens in the pulmonary microvasculature. These megakaryocytes on the left come in, park in the lungs, and they release platelets via interactions with endothelial cells of the pulmonary microvasculature. They have shown without any, really strong evidence, not just in this study, but other studies, that the number of platelets that enter the pulmonary microvasculature is X, and the number of platelets that leave the pulmonary microvasculature is much higher than X, and vice versa for megakaryocytes. You got a bunch of megakaryocytes coming in and much less leave, which basically says the megakaryocytes in the lungs essentially, release platelets, as they interact with the endothelium. This is a little schematic showing that that's what's happening in the pulmonary circulation, in the microvasculature. Megakaryocytes on the left, platelets on the right. And I want to introduce another concept. As platelets get activated in this disease, or even other, diseases, where you have, let's say, your leg is run over by a car and you have a bunch of thrombi being formed. Obviously, the body's like, let me fix this for you. Your leg's all messed up. Let me close off all the bleeding and all the pathogens and everything. It releases a bunch of stuff. Platelets release fibrinogen, von Willebrand factor. They release PI1. They release ADP and serotonin. And, these mediators essentially bring in all the other cells and, cut the blood supply to the area, cause vasoconstriction, cause all sorts of vascular permeability in the very little area of injury. They kind of let the cells seep into the interstitial, space and the parenchyma, and kind of, close off the wall off the pathogens and do all sorts of things to basically heal the site of injury. And, lungs have a role in clearing one of the mediators or more in platelet activation. Somebody has to clear all the mediators that are released, and kidneys probably do some, liver does some, other cells that are scavenging do some. But really, truly, the lungs take care of the serotonin and somewhat norepinephrine, somewhat ADP, but really the serotonin. In fact, 98% of serotonin in the body freely circulating, within one pass through the lungs, it gets cleared. Lungs are the organ where serotonin is cleared. And I've tried to show that here by showing that you got thrombosis on the left, you got platelets that are active, serotonin is released, comes through the lung, breaks down, goes to 5-HIAA, you pee it out. Same platelets that are getting kind of released from the lung, load up with serotonin, and they leave the lung vasculature, essentially, kind of re-energized and ready to go to kind of do what they need to do. Pulmonary arterial hypertension is a disease where serotonin is, highly implicated. The platelets that enter the pulmonary circulation in PAH essentially leave the pulmonary circulation depleted of their serotonin. This has been shown in this study, where transpulmonary platelet gradient in normal people is 30, positive 30. You enter the lung at X amount of serotonin, your platelets leave the lung at X plus 30. Whereas in pulmonary arterial hypertension, it's the opposite, it's negative 10. You enter the lung at X, you leave at X minus 10. And another disease where platelet activation in pulmonary microvasculature does something is high altitude, acute hypoxia. We have evidence that, this kind of exposure causes endothelial dysfunction in the pulmonary microvasculature, causes platelet activation, and probably, goes through the same cycle where, the lungs are influenced by serotonin, and it causes vasoconstriction, as a response. And they call that hypoxic pulmonary vasoconstriction. And that vasoconstriction is really, really, truly mediated, again, by serotonin that are released from the lung itself, from these neuroepithelial bodies in the lung. It kind of brings up the question of how acetazolamide works. We don't really know how it works, but there's evidence that acetazolamide actually, right in this highlighted area, acetazolamide added to essentially stimulating lung with hypercapnia or acidemia. When you add acetazolamide, it actually reduces 5-HT serotonin release, as opposed to all the other things that we think and we hypothesize acetazolamide does. This is potentially how this disease is affected by acetazolamide. Carbonic anhydrase inhibitors, again, work on platelets. They reduce platelet aggregation. They reduce aggregation due to adrenaline and serotonin. And yet another disease where serotonin and platelets play a huge factor, and I highly recommend people to read this study, is essentially immune complex mediated platelet aggregation in the lungs and serotonin release. And in that study, essentially, they have demonstrated very elaborately, beautiful study where they induce immune complex mediated inflammation, and they notice that platelets get super active. They go and release 5-HT or serotonin in the circulation. They cause shock. They actually cause hypotension that's mediated by serotonin. And then the platelets go park in the lungs. They sequester themselves in the lung, and they actually release serotonin also in the lung, cause vasoconstriction there. They leave the lungs degranulated, void of their serotonin. So getting back to COVID, again, we know that it causes endotheliitis, and we know there's a bunch of platelet activation and platelet-rich thrombi in the pulmonary microvasculature. I hope I showed you enough evidence for that in the previous autopsies from New England Journal of Medicine and Lancet. And there is a possibility that these platelets, in the same scenario as in altitude hypoxia, in the immune complex, and also in pulmonary hypertension, we have evidence after evidence that when you activate platelets in the lungs, you degranulate these platelets, and they release these, chemokines to essentially tell the body to come and wall off this pathogen. There's an injury here. Please bring in leukocytes, bring in other things. And, there's evidence that in COVID-19, you have increased fibrinogen, increased PI1, and increased von Willebrand factor. And if you notice, all of these three things are within platelet granules. And, there's possibility that platelet hyperactivation in this disease may mediate all of these things that are causing clots after clots after clots systemically, that are causing heparin resistance, as it's been demonstrated in several studies. So now we finally have evidence that platelets are hyperactivated in COVID-19. This is a beautiful study out of Canada and Morocco, where it shows that in healthy patients in blue, your platelets are essentially, they do what they do. It's blue. In non-severe COVID, and then in severe COVID, you have much higher aggregation of platelets, as demonstrated in these graphs. And if you look at the platelet content of serotonin in the bottom on the left, they have a lower platelet content of serotonin in COVID-19, severe, and then non-severe, and then in healthy, in the blue. The healthy subjects have a normal amount of serotonin in their platelets, and as COVID-19 severity increases, the platelets degranulate. They get rid of serotonin, they get rid of platelet factor 4, and all sorts of other granules. And if you look at the bottom right, the plasma free serotonin in healthy subjects is normal, it's the blue dots. And you have a vast increase in plasma serotonin in COVID-19 patients. Um, so I've tried to kind of show this in a little graph here that, you know, potentially we are dealing with a platelet hyperactivation syndrome in COVID-19, precisely because the platelets are produced in the pulmonary microvasculature. 50% of our total body platelets are produced in these vasculature. And if there is an injury to the endothelium, if there's endothelial dysfunction from COVID-19, then you're going to have this biogenesis, just a poor generation of these platelets potentially being produced in a hyperactive state, and not just in a hyperactive state, but also being produced in kind of a pulmonary microvasculature that's constricted, that's flow restricted, and that's not really properly, kind of flowing in a proper fashion. So you're probably going to get a buildup of platelets that are just being activated more and more and more. They're releasing these chemokines, whether it's serotonin, histamine, ADP, whatever it is, and it's attracting more and more and more platelets and more neutrophils and leukocytes, and they're basically just like, it's getting into a feed forward kind of a vicious cycle where you're, no matter how much you anticoagulate them, if you're not dealing with the platelet hyperactivation, you could potentially continue to get more and more in situ thrombosis and more refractory thrombosis and PEs and whatnot. And part of this process, if we are to believe there is some sort of a vascular shunt, right to left shunt in the pulmonary vasculature being developed, it is not far-fetched to assume that this released chemokines, serotonin being one of them, could reach systemic circulation through these shunts without being processed in the lungs as it usually should be. Remember, 95% of it is cleared by the lungs in one pass. But in COVID-19, there's a very likely chance this is not happening properly. And essentially, this slide kind of just summarizes that we have targets here to address what's going on with platelets in this disease. On the right side in the red, you can reduce the thrombosis by anticoagulants. You can reduce platelet activation by antiplatelets, which is not part of necessarily what we're doing right now, at least widely. Platelets do release histamine, and histamine has been shown to cause pulmonary venule vasoconstriction and actually aggregate more and more platelets among with other mediators. So there is plenty of rumors that these long haul patients with COVID improve drastically with Pepcid and histamine blockage. So there is plausibility that if you block histamine, potentially you could have some benefit in this feed forward vicious cycle. Essentially, the serotonin and the platelet derived growth factors and whatnot all can lead to vascular remodeling of the lung, just like it happens in pulmonary arterial hypertension, probably over longer course, but here kind of in a faster state, as the New England Journal article showed. It's happening 3 times as fast or as intense as influenza ARDS. You're having vascular neogenesis. And you can probably prevent some of that vascular neogenesis by heparin. It's been shown to decrease vascular remodeling in studies where they actually expose pulmonary arterioles to serotonin, and heparin actually reduces vascular remodeling. So I think in addition to having an anticoagulant effect, heparin could also have an effect in addition to that by also reducing vascular remodeling. Is there any role for serotonin antagonists? I have no idea. Who knows? I'm just putting it out there. And finally, that intrapulmonary vascular right to left shunt, where we think some of these chemokines, some of these platelets and megakaryocytes that are just not being able to go through this restricted, flow restricted, kind of messed up pulmonary microvasculature due to the viral injury. If some of that stuff can't get through properly, it's gonna spill over and it's gonna find its way through these shunts one way or another, probably find its way to the systemic circulation. And you're going to have these hyperactive hot platelets running through the body, and you're going to have these hyperactive kind of platelets, microparticles, which are even more hypercoagulable. And you may have some of these chemokines spilling over to the systemic circulation, as that study showed with plasma-free serotonin in these patients. And you can have hypercoagulable state from that. You could have systemic effects by histamine, serotonin, and other things. And that's kind of what I try to show in this slide is we might have to think about whether some of the weird systemic things we're seeing in COVID are due to these chemokines. 5-HT causes everything on this list. Causes bronchoconstriction, can cause inappropriate hyperapnea where patients are just rapidly breathing for no clear reason. They're not hypercapnic, but they're just having respiratory rates of 30 and 35. And when they're on the ventilator, this causes ventilator dysynchrony. They're having shock, hypotension for no clear reason. And remember the study I showed where serotonin was basically mediating shock in immune complex inflammation. In fact, it's been shown that I think adrenaline stimulation can potentiate, can worsen the effect of serotonin systemically on a bunch of these targets. It probably may not be the greatest idea, and I have no idea if this is accurate, but it may not be the greatest idea that we're putting these people on, norepinephrine and epinephrine, and we're seeing that they require more and more and more and more pressors, and it's just like, what happened exactly? They're on every antibiotic known to man. They're not in cardiogenic shock. Nothing else is happening, but they just require more and more pressors. So there's a possibility we're kind of missing the picture there, that this may be related to serotonin. The unexplained fevers, the arterial venous thrombosis. Remember heparin-induced thrombocytopenia? The assay for that is serotonin release assay. That causes refractory arterial venous thrombosis. So we're not going too far there by thinking that hyperactive platelets could potentially be causing a very similar picture to HIT, mediated by serotonin and other kind of pro-aggregating chemokines. Obviously, back to kind of my field, diarrhea and serotonin, I don't have to explain too much there. It's clearly there's a huge link there. And mesenteric ischemia can happen with excess serotonin. Cerebral vasoconstriction. There's a study that came out of France that showed PRESS-like, MRI findings in these patients, and there's report after report after report of association with PRESS, cerebral vasoconstriction, and serotonergic medications. My fear a little bit is, I also read a study where steroids worsen cerebral vasoconstriction in these patients, and they worsen the outcomes. So that's a little worry I have on the dexamethasone, as great as that is, and I'm very happy we have something to work with, but are we potentially causing neurologic issues, that may not be fatal, but could they be significant in the subset of patients getting dexamethasone? I have no idea. Again, central sleep apnea, long haul neurologic symptoms sound awfully like serotonergic to me, although I have no proof of it. And so we have to think about whether there is not just a lung process, but also a platelet hyperactivation and possibly a chemokine from platelet hyperactivation in these patients that potentially may explain all of these weird systemic things that none of us can really truly explain. People say, oh, they're breathing too fast because they're hyperinflammatory, or there's a cytokine storm. And I'm just, I constantly keep searching for answers. I'm like, well, what is causing it? What exactly is happening? You can't just say hyperinflammatory. That's such a vague term to me. But anyway, I'll move on. And in terms of the targets to treat, again, you guys are well aware that we are using anticoagulants. We don't have any randomized controlled trials. I have hope that it is doing something, preventing some damage, and I think they have a role in more of a preventative process to prevent all of this that's on the slide on the left from happening by reducing the chance that this thrombosis in the pulmonary microvasculature gets out of control, gets to that vicious cycle that I've tried to explain here. I think if you let it go too long, there's not a whole lot we can do to reverse that, because the vascular remodeling and the intrapulmonary shunting of these chemokines, it kind of just gets things out of control. I personally think there is a ceiling effect to anticoagulants beyond which you're not going to get much more benefit, just like in myocardial infarction. You probably need antiplatelets to deal with it, but we're not even there with anticoagulants in terms of trials. And then now we have to add antiplatelets to the trials. I mean, I think we're gonna have several months before we have clear evidence. But I've tried to put out a plausible explanation why antiplatelets may be very helpful and may play a very large role in this disease to kind of prevent this cascade of events. Along the same line, things that are not very harmful that could plausibly be helpful, I've tried to, make the case that histamine plays a role as a chemokine here, that serotonin plays a role as a chemokine here, and really adrenergic stimulation will worsen the platelet aggregation here, mediated by serotonin, histamine, and other things. And there's plenty of evidence for that. Adrenergic stimulation probably mediates serotonin effect on carotid sinus, where I think probably the rapid breathing that's inappropriate is happening. And there is one study out of France that showed clonidine actually decreases this rapid breathing and this ventilator dyssynchrony. So I think we're kind of getting some evidence there. There's something going on probably with these chemokines. Probably there's some sort of a stimulation by adrenergic receptors that's leading to some of these systemic effects that we can't explain. And really, I just want to emphasize again that please take all of this with a grain of salt. I don't have clear evidence on most of this. There is certainly harm that we could cause by adding these medications. So please don't take this as, I'm going to go ahead and try all these things on my own. Please, informed consent is the way to go. Discuss with patients, discuss with families that we've tried everything and we think this might work or this may not. Discuss with your colleagues. Please don't go and try these things, just out of the blue from this lecture. We really, truly need randomized controlled trials to see if any of this really is actually helpful, and what's the number needed to treat is and what's the number needed to harm. And, it's a tough world out there, and not being on the front lines in the ICU treating these patients, I empathize with all of you that kind of want to do something and want to prevent that bad outcome, but and ideas exist such as this and many other people that have great ideas, but you're not sure how to do it, and whether you would do it or not, or whether you would do it for your loved one. But again, I've just tried to make a case for possible explanations of what's happening in this disease. I wish all of you the best of luck, and if I can help answer any questions here, please let me know. And I want to again thanks Mark for letting me have this forum to kind of present some of my ideas. Thank you.